Hello, sir. Hello. National Chairman, sir. National Chairman, sir.
I think it's no more on the call. Maybe that's a network issue. Can you call in directly with your phone?
Okay.
Yeah.
Let me call him and tell him that we're about beginning. Good morning, colleagues. Just be patient with us. We're about starting. Thank you. Good morning, colleagues. Can you hear me?
Yes, we can hear you.
We can hear you.
Okay. Good morning, colleagues. My name is Pharmacist Akele Gabriel. I'm the National Editor-in-Chief and the moderator for this Zoom meeting. The National Chairman is on another call, and we can't keep waiting endlessly. So we'll begin this meeting in earnest. Pharmacist Kehinde, National Treasurer, ma. Pharmacist Kehinde. Good morning, ma. Can you say the opening prayer for us? Pharmacist Kehinde. Can someone say the opening prayer for us so that we can begin? Hello, good morning.
Good morning.
Please, can someone say the opening prayer for us? Pharmacist Kehinde is not responding.
Heavenly Father, and everyone, to thank you for giving us these days. And we pray that at the end of our deliberation, we shall all have cause to glorify your name in Jesus' name. In Jesus' mighty name, we've prayed.
Amen. Good morning, distinguished colleagues. I hope I'm audible enough.
Yes, you are. Please go ahead.
Am I audible? Okay. Good morning, colleagues. The National Chairman, all National ESCO present, guest speakers, Dr. Lawrence of the National TB and Leprosy Control Program, Pharmacist Adewumi. We appreciate you for making our time to be part of our meeting today. As you are all aware, today we're celebrating the World TB Day, and the theme for this year is Invest to End TB, Save Lives. At our various institutions, I know we are involved in one way or the other in the management of TB. And even if we are not currently, I know some years ago, many pharmacists were involved. I recall very vividly about 15 years ago in Taraba, where we used to compound anticox for 15 patients every day. Over time, this burden seems to have been reducing, but we are aware that new infections are springing up. So today we are going to be discussing this burden in our healthcare delivery system, tuberculosis. And before we start, we want the national chairman to give us an opening remark before we continue with the program. National chairman, sir.
Yeah, thank you very much.
National chairman, sir.
Yes. I hope you can hear me. Am I audible?
Yeah, audible, sir.
Okay, thank you very much. This World Tuberculosis Day 2022, opening remarks by Pharmacist Olabode Ogunjemi of FPSN, AHAP National Chairman. As a matter of protocol, I want to recognize the fellows of the PSN, fellows of the West African Postgraduate College of Pharmacists, distinguished service awardees of our great association. AHAP NEC, I recognize you. AHAP council members, Confi chairman and the members. Then, of course, all AHAP members here present. It is with great joy that I welcome you all to this year's World Tuberculosis Day celebration. As part of our promises to ensure that pharmacists are kept abreast of information about happenings in the health balance, AHAP NEC resolved to observe all the WHO Health Days in the current year. The World Health Days is part of the mandate of the Publication and Drug Use Enlightenment Committee, and I'm really glad they are playing that role. Historically, 24th day of March every year has actually been set aside to mark the World TB Day. In 1882, Dr. Robert Koch announced that he had discovered the bacterium that causes TB. That is the Mycobacterium tuberculosis. World Health Day is observed, like I said, on March 24th every year. And the basic reason is just to raise public awareness and, of course, understanding about the fact that TB is one of the devastating health, social, and economic, it has social and economic impacts on people around the world. Then this year, we look at the team. The team says invest to end TB, saves lives. Why do we invest to end TB? This particular team is just to convey the urgent need to invest resources to revamp up the fight against TB. And of course, to achieve the commitment to end TB made by global leaders. We are all aware that in the year 2020, when COVID-19 pandemic came on board, it actually has a lot of effect on putting an end to TB. So the progress so far is actually at risk because of COVID-19. Of course, to also ensure equitable access to prevention and care in line with WHO's drive towards achieving universal health coverage. Of course, when we invest, millions of souls or lives will be saved. And of course, there will be acceleration of, or rather to put an end to TB epidemic. Just a little statistics, because I'm not the keynote address speaker. About 1.5 million people died from TB in the year 2020, according to WHO. And TB is actually the 13th leading cause of death and the third leading infectious killer after COVID-19. It's also on record that each day, over 4,100 people lose their lives to TB, and close to 28,000 people fall ill with this preventable and curable disease. Estimated 66 million lives have been saved through these global efforts since the year 2000. For the first time in over a decade, that's talking about year 2020, TB deaths actually increased. I'm sure we remember that the focus then was basically on TB, and nobody was really focusing attention too much on all other ailments. Then what are we to invest? Of course, we need to invest our time for enlightenment programs on radio and TV. And of course, this type of program that we are holding is one of those things that we need to invest in. Of course, we need to invest our resources, our expertise. Like the moderator said, they were doing compounding of anticox for pediatrics. These are some of the areas in which we need to invest. Of course, our professional calling, talking about pharmaceutical care and all that. I want to appreciate the resource persons, Pharmacist Lawrence and Pharmacist Bengadeumi. Both of them are from the FCT. These people have been carefully selected to do justice to the topic. So we just want to plead with every one of us, especially the guest speakers. Let us speak within the time frame so that we'll be able to end this program on time. Once again, I welcome you all to this meeting. Happy listening, and God bless. Thank you.
Thank you, National Chairman, for that brief remark. Before we go on, I would like to quickly make a few introductions. I'm aligned with the existing protocol that the National Chairman has already established. I would like to say that our moderator for today is Pharmacist Abdullahi Hafsat of the FCT, and the host of this program is Pharmacist Hafsat Maman. So I want to welcome each and every one of us as we continue. Pharmacist Hafsat Abdullahi, please, can you continue from here? Thank you.
Thank you very much, Pharmacist Gabriel. The chairman and other members from other pharmacists present. Good morning, all. Please, I want to stand on the existing protocols. Without wasting much we're going to
unmute yourself, please.
Okay. Our first presenter for today, from Dr. Ekyocha Lawrence. I'll take a brief citation on him before he does his presentation. From Dr. Ekyocha Lawrence is the country procurement and supply chain specialist at the Program Management Unit of National TB Program under the Global Fund Grant. He has postgraduate degrees and certification in public health, health economics, as well as development studies from University of Benin and Bayero University, Kano. He has more than 10 years experience and progressive knowledge in HIV, AIDS, malaria, and TB. Currently providing technical support and assistance, providing data visualization and back-end visibility of logistic management information systems of the supply chain system in Nigeria. He has led the pilot phase of the investment model of public-private partnership of the USAID's Sustainable Financing Initiative across high-burden states. Brings wealth of experience from the public health, TB, and HIV space. So, ladies and gentlemen, I'll hand over to Pharmacist Lawrence to make the presentation. Lawrence, you are welcome.
Good morning, colleagues.
Good morning,
National Chairman, and all our distinguished colleagues. All protocols duly observed. Tonight, I'm going to be speaking as the focal person appointed by my superior, Pharmacist Raji, to take this brief discussion. So I'll be sharing my screen so that we can quickly start the discussion. Okay. So I don't intend taking much time. So briefly, I want us to TB whole area. TB. Since today is what TB day, let's look at TB in Nigeria. But before we look at TB in Nigeria, let's take a look at the global epidemiology, as it were, and have a good understanding. So we do know that TB is an highly infectious airborne disease, but is curable. 1/4 of the world population, approximately 1.9, some of which are latent, are people infected with TB. The truth is, every one of us has TB living inside of us, every one of us. But it's just the immunity that differentiates you and from those who have active TB. When immunity is strong enough, you are likely not to come down with TB. So 1.9, some of them are latent, and there are people infected with TB. So of the 1.9 billion, every year, 10 million So every year, 10 million people develop TB, and of them, 1.1 million children and 860,000 people of them are living with HIV. So these are people who are co-infected with HIV. 860 of them are PL HIV, and then 1.1 million are pediatrics. And approximately 3 million people of this category are missed out of the TB care cascade. So it's a big challenge. Also, every year, nearly 500,000 people develop drug-resistant TB. Drug-resistant TB has become very common amongst us now, and 1 in every 3 is only able to receive treatment. Okay, so currently TB, So TB in Nigeria, let's look at the country profile. So we are ranked 6 among the 30 high burden countries globally, and we are first in Africa. So this accounts for about 11% of the global gap between TB cases. The country recorded about 50% increase in TB notification from about 108,000 TB cases in 2020 to about 207 cases in 2021. So there was a great spike. And of these, 6% of notified cases were children less than 15 years of age. Of an estimated 21,000 DRTB cases, underline DRTB cases recorded in 2020, only about 2,000 plus, which are about 10% of them, were diagnosed. And of these 10%, only 10% of them were enrolled on treatment. So you see, there's a great gap. We need to understand that dot clinic is only available in 44% of our health facilities in Nigeria. And of these 44%, only 9% of them have TB diagnostic services. It's another challenge again. An estimated 18 persons die out of TB-related disease. And this is about 433 days and around 56,000 every year. So the World TB Day, each year we commemorate World TB Day on 4th of March. The essence is to raise public awareness, health, social and economic impact of TB, and urge acceleration of effort to end the global TB. That he had discovered the implicating bacteria. So TB remains one of the world's deadliest infectious killer disease. Each day, about 4,100 people lose their lives to TB, and nearly 30,000 people ill with preventable but curable disease. Global effort to combat TB have saved an estimated 66 million lives since the year 2020. However, the COVID-19 has reversed progress made in the fight to end TB. So there's a global call for accelerated action to end TB, and to end death of TB, especially in the midst of this ongoing COVID-19. So we recorded a great, huge of progress towards ending TB, but there was a great reversal, during they shared similar symptoms. And then there was a shift of attention to COVID-19, while we left TB, we left HIV, and other infectious diseases unattended to some extent. In fact, there were some treatment centers, DRT patients being managed were converted to isolation centers. So you see, that affected us a great deal. All right. So the theme of the World TB Day, like we know, is invest to end. The slogan for Nigeria was, or is rather, give more, do more, and end TB now. So like the title conveys itself, there's urgent need to invest resources, global resources in terms of human resource for health, in terms of technology, health technology, and healthcare commodities, in terms of infrastructure to be able to capture real-time data. So these are the resources we are talking about. Innovative technologies to increase case findings. All these are the resources that are needed. This is especially critical in the context of COVID-19 pandemic because it has put the TB progress at risk. And as such, more investment to TB will save millions, more millions of lives and accelerate the end of the TB epidemic. Let's do some financial outlook to funding as to ending TB. So you see, globally, about $15 billion annual funding for TB was promised by world leaders at the United Nations high-level meeting in 2018. But surprised to know that less than half has been delivered. and there's a gap to this. Currently, what we have is about 30% funding for TB control, 30%. And of the 30%, 7% is only domestic and 24% is donor. So you see, there's still a gap of about 69% to 70% funding gap. So this gives us a whole lot of challenge in the treatment, prevention, treatment, and management of TB cases in Nigeria. The funding gap is a bit wide. So this is just to, again, repeat what we do on every World TB Day. This is what we actually do. On the 17th, we start with sensitization, and then we'll go round and round and round. I won't bother myself to look at this. I will dwell more on the next slide, where I'm going to dwell more. Yeah, so as pharmacists, I like to share this with every one of us because this is where I feel we can contribute a great deal, So these are the innovative strategies, National TB and Leprosy Control Program, as well as other implementing partners in country are doing strategically to increase case finding and then to bring to treatment and care those who we find. So it's an expansion of TB services to health facilities that that do not carry out DOT services. So within the last 2 years, we have activated a lot of sites, expanded to a great deal health facilities to carry out TB services. This is 2020. Yes, in 2021, our facilities increased close to about 10 to 12,000 health facilities. Yes, it was a bit less than that, but within last year, 2021 and this year, there's been rapid expansion, mapping our facilities to increase TB services across the nations where DOTs were not actually being, services were not being provided. Number 2 is inter-facility outpatient department screening of patients for TB. So this is being done in OPDs of all hospitals, mostly general hospitals, secondary facilities, where on OPD screening days, TB services is provided for. Patients who come are all screened, for TB. Again, this is just to increase case finding, and then as we identify them, we place them on treatment. Because in TB, we have a logo that 100% of people who are living TB must be identified. That same 100 must be placed on care, and that's the most achieved cure, at the end of the treatment cascade. So this is our push and our guideline from United Nations and the Stop TB Partnership. Number 3 is house-to-house and community case search and awareness creation strategy. So we have CBOs, we have CSOs, and other organizations who go from house to house and from community to community doing active case search, and generating awareness and demanding, generating awareness, such that TB is funded. So there's an active case finding. Number 4 is TB case finding among key populations. Key populations are people who are, so there are 2 kinds of people here. There's a gen population, and then there's a key population, particularly in the HIV space. HIV space, the general population are everybody. But there's a category, a set of people that they call key population. These are people like men who have sex with men. These are like female sex workers. These are like people who inject drugs into their system. These are people like gay and the rest of them. They are called key population. So there's an active case finding among this set of people, both in the IDP camps, among the nomad settings and all that. There are people we have contracted to help us go out there and find these cases among these people. Number 5 is contact tracing strategy. Contact tracing strategy like partner notification services, index case finding. This has been very strategic because for partner notification, it's just to elicit anybody who comes down with TB, a confirmed TB patient who want to his partners, who want to believe that he's not living in isolation. So want to trace him to his household, his wife, if he's married, his children, if they're of age, his house help, if they have, and like that. So we call them partner notification service. For those who are married, we want to tell the husband that your husband, your wife has this disease and he needs to be managed. Are you aware? Of course, this is done with all protocols followed. We don't break any protocol, but we try as much as possible to ensure that partners are notified and given such services. And then the other one is index case finding. So an index case is somebody who a confirmed positive. Then you want to find people who have ever associated with this particular person who is positive. It could be the mom, could be the dad, the brother, the sister, the auntie. If he's in a school, his close friends. So we use that person as an index case to trace people around him, and then do test them for TB. And that worked a great deal. I mean, that's worked a great deal. We found a lot of confirmed positive cases among, this category of people. And so the other one, number 6, I want to talk about is using some technologies to detect TB within the system. It will, of course, DRTB cases is man-made. We need to know that DRTB cases is man-made. First of all, without TB or DSTB, drug-sensitive TB, there cannot be DRTB. So we have come to agree that drug-resistant TB cases are man-made. Somebody who's not taking his drugs well and then shares the infection with somebody else, automatically that person can come down with a drug-resistant TB. So we know it's a man-made. However, there are other molecular rapid diagnostic devices, technologies that have been put in place to help us detect, such cases. Now, one of them is expert MTB RIF. So this is a gene expert that help us to detect TB patient, or TB rather, that is resistant ab initio. So gene expert is a good standard test, for confirming positivity. And then it helps us also to do a deeper analysis to know whether or not that patient is resistant to any of the drugs that he or she will be placed on. Again, we also have expert TB RIF Ultra. This is superior to the first one I mentioned. Okay, this helps us to detect further, resistance further down the line. Is it implicated with isoniazid? Is it implicated with rifampicin? Is it on any of the backbone commodities? So we also want to know. There's another one that they call Gene Expert extended drug resistance. This is a new technology, and it's called a 10C color cartridge. 10C color cartridge. This one does wonders because it goes as far as helping us to detect extended drug-resistant TB, ab initio, extended. There's also the one that are called TrueNAT. TrueNAT. These ones are a bit mobile. Gene expert machines are a bit big, and you can't move them everywhere. But TrueNAT, whether TrueNAT, MTB RIF, or DL+, they are so portable such that you can move them everywhere. You can even move them to campaign sites, outreach sites. Once you collect your sample, you can run them real time right there, and it gives you the results. So the advancement with this is that it's portable. It can be moved, anywhere you want to go to. Unlike the Gene Expert that you need it needs a very cool environment. It needs to be positioned and then monitored per time as per electricity, temperature, and the rest of them. Unlike the TrueNAT is mobile, you can use it anywhere. It also helps us to detect drug resistance, plus other indices that we look at for when the test results are out. TrueNAT can also help us to detect that and then better inform clinicians on which commodities they can be placed on. So there's a TB lamp, there's an F lamp. These are also new technologies that we have rolled out such that, you know, as soon as patients are gotten, we run the necessary tests and then they are placed on care as much as possible. Instance where a baby, sputum cannot be collected from a baby. Of course, most times it's difficult from pediatric to collect sputum from them. So it's possible to collect the stool of that patient, you know, run it on either TB lamp or LF lamp, and then the result, you know, comes out, and then the patient can be placed on treatment. So these are the strategies that National TB and other implementing partners are operationalizing, you know, to increase case finding, we're making a great deal of progress. So I won't bother with this. These are just our sites, you know, where you can get further information and the likes. So I want to say thank you here and entertain questions if there are. Thank you.
Thank you very much, Dr. Ikocha, for a very insightful presentation. Please, let's keep our questions and comments. Pharmacist Benga Adeomi. I will read a brief citation of Pharmacist Benga. Yes, Pharmacist Gabriel.
No, we are listening, ma. Go on.
Okay. Okay, I'll read a brief citation of Pharmacist Benga.
Yes.
Pharmacist Benga Adewumi graduated from University of Jos 2010. He has an MSc in pharmacology from University of Lagos. He's a chief pharmacist at Federal Capital Territory Administration (FCTA), and his present post is Kuje General Hospital. He's the focal person for Kuje General Hospital on TB and leprosy, and he has attended several trainings on TB, which include in December 2021, he attended tuberculosis diagnosis and management workshop for general healthcare workers in Nigeria, organized by the Federal Ministry of Health in conjunction with WHO, GF, and TLM. In 2019, he also attended training on DOT officers organized by the FCT TB and leprosy program in conjunction with Tuberculosis Foundation Nigeria. In 2017, also attended infection prevention and control training organized by the Department of Public Health, FCTA. So Pharmacist Benga is our second speaker. Please, Pharmacist Benga, you can start. Pharmacist Benga, we're not seeing your slide. Okay. Please enlarge it.
Just do full screen.
Click on slideshow.
You can make it full screen, sir.
Yes, or slideshow.
Pharmacist Benga, you can start your presentation.
Pharmacist Benga, are you with us? Pharmacist Benga, are you with us?
Yes, I'm here, but please, I need to be able to unmute myself.
Okay, okay, you've unmuted yourself, right?
Then we can hear you.
Okay, we can hear you now, sir.
Okay, all right, thank you very much. Okay, what about my slides? Please, can you see the slides?
We can see it, but you are not doing slideshow.
Okay.
You will have to go to slideshow and start from the beginning.
Okay, perhaps. All right.
We're not seeing the slide.
Yes, I'm sharing my screen already.
Okay, but we can't see the slides, sir.
That's serious. Slideshow.
Okay, it's okay now. Go to the first slide.
Okay.
Start from the beginning.
Is it okay now? Hello?
We can see it now. Yeah, it's okay.
All right. Thank you. Sorry for the technical issues. Okay. Please, good afternoon already, my distinguished senior colleagues. Please permit me to stand on the existing protocol. My name is Pharmacist Benga Adewumi. Today, my assignment has been made quite easier by my chief, who has presented earlier ahead of me, and the chairman as well. They have already done justice to the topic. However, my assignment here involves just increasing and raising awareness among us as regards TB. All right, just a brief one. This has been dealt with already. 24th of March every year is a day selected by the WHO to commemorate the discovery of the mycobacterium tuberculosis by Dr. Robert Koch. I won't waste time here again because this has been dealt with. All right, so I really want to say this about the World TB Day. The message that I want to bring across to us for us to observe the World Tuberculosis Day is first for you to get tested. Remember, disease prevention, they say, it always starts with you. And as you progress, you will see the burden. In fact, the burden of TB in Nigeria has already been dealt with. So let me just go straight to tell you that, of course, as you are all aware, the test and even the treatment is totally free. And of course, it is better to have it in your medical records than for you to have it in your lungs. This is the message I always tell people. Get tested. And if you are positive, the good news is that it is curable and it is totally free. Now, the second thing I would like to say here is that I want us to spread awareness on TB so that we can end the spread of TB. And I am glad about our meeting today because that is exactly what we are doing. But I want to urge each and every one of us that this message should not stop among us here. The truth is that quite a number of people infected with tuberculosis do not even know, and some of them that know, they do not know what to do about it. Remember, tuberculosis is regarded as an ancient disease, and it is also known to be the disease of the poor. Quite a number of them are in the rural areas where they do not have equal access to healthcare facilities like we do. So we were privileged to have this information. The onus is now on us to spread the news to other people who might be living with tuberculosis. Also, I will want to say, while we are doing this as pharmacists, I want to challenge each and every one of us that there is a huge need for us to volunteer. Yes, the theme of the year has already said it all. We need to invest. So why policymakers are there, why the government is there trying to source for funds, trying to make commodities available. But as pharmacists, as individuals, there are things that we can also do to put an investment into the fight against TB. And that is where volunteering actually comes in. Quite a number of people that I know that are into the National TB and Leprosy Control Program as DOT officers are actually volunteers. So I want to encourage every pharmacist and everybody on this call to find somewhere to volunteer. If you do not have a facility, which I do not believe, I believe every one of us on this call has one facility where we are practicing. You must not even be the DOT officer there. You can just be there to even identify suspects, or let me say presumptive TB cases at GOPD level. You can be there to give information about cough. And you can also volunteer in the community. We have community volunteers that we work with. So we have other people in the community that are responsible for feeding us with information at facility level. So there is absolutely no excuse for us not to invest something. We can invest our time, we can invest our expertise into the fight against tuberculosis. All right. Here, why World Tuberculosis Day is important. As I've said earlier, many people are still suffering from tuberculosis. Chief said about 1.9, I got information that over 2 billion people are actually infected with tuberculosis. And it may surprise you to know that the disease is closer to you than you think. Yes, you might not have it. Yes, none of your family members might be suffering from the disease, but the burden in Nigeria is so high. We are the first in Africa, and we have the 6th highest burden in the world. In fact, while I was, doing some check, I came across this saying that every year, look at the figure, very, very disturbing. Then I also now realized that more than 10% of all deaths in Nigeria has to do with tuberculosis. Despite the availability of effective treatment, nearly 30 people die from this disease every hour. So it is a very, very disturbing thing. But the good news is that we can actually end TB in our lifetime, and just spreading the news about where people can get treatment and what people should do can actually go a long way to put an end to the disease. Okay, what is TB? This one, I'm not going to waste time again because it's been dealt with and we all know, so it's just to serve as a reminder. Tuberculosis is a chronic infectious disease that is caused by the bacteria that we all know, referred to as Mycobacterium tuberculosis. It mainly affects the lungs, but it can also affect other organs of the body, where we call it extrapulmonary tuberculosis. It is mainly an airborne disease, and it is transmitted when an infected individual coughs and expel the bacilli into the air. Then someone else now inhale. And remember, it is not only through cough, even sneezing, talking, and as people are spitting can actually liberate some of these bacilli into the air for another person to inhale. Right. This is just to show you the volume, the number of the bacilli that can be released. Imagine about 1 million bacilli released when someone that is infected sneezes around you. And if an individual now inhales this, of course, the person becomes infected, even if the person doesn't progress to the active stage of the disease. Now, the risk factors, basically, I put them into 3 because it is not everybody that is exposed to the mycobacterium that will eventually get infected. And it is not everybody that is infected that will actually progress to disease stage. But basically, progressing to the disease stage, it has to do with weakening immune system. As my chief rightly said, once you are infected with the mycobacterium, it can just remain latent for years until any factor that has to do with maybe taking cytotoxic drugs, anti-cancer, chronic alcoholism, systemic illness, anything at all that can actually suppress the immune system can now make someone that is already infected to progress to the disease stage. And that is why TB is a serious issue in people living with HIV, because there's tendency that their immune system is already suppressed. And as such, in fact, any cough at all seen in people living with HIV should raise a very high level of suspicion for tuberculosis. Now, the burden, initially when I was talking, I said we're going to talk a little more about the burden, which I've said already. Now, where I want to dwell on more is on the missing cases, actually. The missing cases has been on the increase since we started the NTB strategy in 2016. You can see the figure. The figure has been on the increase for missing cases. And unfortunately, part of these missing cases could be resistant TB. In fact, not even could be, are actually resistant TB cases. You can see that only 1 out of every 4 infected TB patients actually gets to the point of diagnosis and treatment, leaving 3 out. And out of these 3, there is a very high tendency that a number of them will be resistant cases. So it is important that we all come on board, put our hands together to trace these missing cases. All right, the missing cases in graph, as I've said earlier. Now, how do we identify presumptive pulmonary tuberculosis? Now, the most common symptom of pulmonary TB is persistent cough that has lasted for 2 weeks and more with any of these other symptoms, be it night sweat, chest pain, tiredness, weight loss. So once we come in contact with someone who has been coughing for 2 weeks or more, it should raise our suspicion. And as such, we should encourage such individual to go for testing. And remember, diagnosis is free. Now, these are in fact, my chief has already, dwelled on this, but at the facility level, what we currently use is the GeneXpert machine. The GeneXpert test is what we do, because it will help you to pick even the list of the mycobacterium, and it also has the capacity to let us know whether it is resistant or not. For follow-up, we do AFB, we do culture, we do microscopy, but the golden standard for diagnosis is the GeneXpert. All right, this is just a brief interpretation of the sputum results coming from GeneXpert machine. If the result comes out as MTB detected, not detected, sorry, that means the interpretation, that means is negative. And as such, you refer to a medical officer for further evaluation. But if the result comes out as MTB detected and rifampicin resistance not detected, that means, yes, the person has Mycobacterium tuberculosis, the person has TB, but no rifampicin. That means it is drug susceptible tuberculosis, and as such, we treat as drug susceptible tuberculosis. If it comes out as MTB detected and rifampicin resistance detected, this is a case of drug resistance, and as such individual will be treated as MD, as drug resistance TB. These are the other ones. You can have indeterminate. Sometimes there could be error and like that, actually. Now, since we are pharmacists, I felt it would be good to just remind us about the drugs that we use basically in the management of, in the treatment of tuberculosis. As we all know, rifampicin, isoniazid, ethambutol, and pyrazinamide. These are the key drugs that are used in the treatment of tuberculosis, be it adults and in children. Now, the treatment regimens are actually in two. We have the standard one, which is the one that we use more in our facility, which lasts for 6 months for adults and children. The intensive phase, it is divided into two phases, the intensive phase and the continuation phase. The intensive phase lasts for 2 months, then the continuation phase lasts for 4 months. In the intensive phase, you give all the 4 drugs, rifampicin, isoniazid, pyrazinamide, and ethambutol. But for the continuation phase, you give just the rifampicin and isoniazid. Now, in children, the fixed dose combination does not have ethambutol. So if there is need to give ethambutol in the initial phase, you can actually add for that. Now, we use this for all pulmonary TB and extra pulmonary TB, except TB of the meninges and osteoarticular tuberculosis. These are the only exceptions, and it is this exception that actually lead us to the second regimen, which lasts for 12 months. In this case, the first 2 phases, that is the intensive phase, is just for 2 months. And the continuation phase is for 10 months. And we do this, as I said earlier, for TB meningitis and that of osteoarticular TB cases. Now, TB preventive therapy. When my chief was making this presentation, he talked about contact tracing. That is one of the strategies that we have actually, adopted in our facility. When we meet with an index case, we take our time now to do contact tracing, and we try as much as possible to give TB preventive therapy when the patient or when the contacts qualify, because it is not all the contacts that will qualify. So we do screening first for these contacts. For some of them that are already coughing, we send them for gene expert tests so that we can know whether they are infected or not. If the result comes out positive, then we treat them for TB. But if the result comes out negative, then we can now place them on INH. We actually have some other regimen, but these days, what we have with us in the facility is isoniazid. So we place them on INH for 6 months, 300 milligrams, but in children, you do 10 milligrams per kg for 6 months. And the priority group for this preventive therapy are actually contacts of an infectious index TB cases and people living with HIV. Remember, I earlier said that people living with HIV already have their immune system compromised. So any cough at all in them should raise a very high level of suspicion. Now, evolution of global TB strategies. This one, okay, I'm not going to bore us as such with this. The DOT strategy has ended. The Stop TB strategy has ended. Now, from 2016, we adopted the End TB strategy, which is own, pillars and the rest. And what we are practicing in Nigeria is actually, is in line with the WHO recommended End TB strategy. And as I said earlier, it was adopted in 2016. Now, these are the general strategies. early case finding and proper case management, comprehensive management of long-term physical, social, economic effects of the 3 diseases, that is tuberculosis, leprosy, and Brule ulcer. Now, we are trying to promote public-private partnership, behavioral changes, and the rest.
Dr. Gwanga. Dr. Gwanga, are you with us? Mrs. Gwanga, are you still with us?
He's no more on the call. I was given. Yeah. He's no more on the call. Yeah.
He has left the meeting.
Yeah, maybe he has a network issue.
Okay, Mrs. Hafsat. Mrs. Hafsat.
Yes, sir. Pharmacist.
Yes.
Hello.
He has left. At least having network issues.
Okay. Pharmacist Benga Adeumi, thank you for this very encompassing presentation. The first speaker took us through the national program. So the second speaker has taken us through the facility program. I don't know. I think we can start with the question and answer session before he comes up.
If he has not finished the slides, I think somebody can share it now. If you have it, you can share the slides.
No, we don't have the slides. He has this streaming from his own angle, so we don't have it.
Okay.
Yes, sir.
This question.
Dr. Lawrence, is Dr. Lawrence still with us so that I can take 3 questions?
Yes, I'm here. I'm available.
Dr. Lawrence, sir.
Yes, I'm here.
Okay. So, okay.
Is anyone with question for the first speaker?
Before we take okay, as we wait for people to indicate if they have questions. I have an observation, if you can attend to this observation, sir.
Okay. So Pharmacist Benga is back.
Dr.
Okay.
Yes, sir. I think.
Is Dr. Lawrence still with us?
Yes, I'm with you. I'm with you. Hello, sir. I am with you, sir.
Okay.
Yes. Okay. Yes. All right. Sorry about
Lawrence, are you with us?
the little network problem, but I'm actually very close to the end of the presentation.
Okay. Okay.
2 minutes and I'm done. 2 minutes and done.
Okay, sir.
All right. So I was just talking about the general strategies actually. So I will move straight to the structure of the National TB and Leprosy Control Program in Nigeria. I want to just talk to all my colleagues that yes, you might not be at the national level, might not be at the state level, but at least at the local government, at the community level, we can find somewhere to fix ourselves in and contribute in one way or the other. For me, at FCT level, I know my state program manager, and at the level of the local government, Mr. Yakubu Mahmoud is the local government TBLS, that's tuberculosis and leprosy supervisor. And we actually work hand in hand with him. We also have some people in the community, they are called community volunteers. They help us one way or the other in the community. They mix with people. They encourage people to come for testing in the hospital. And sometimes they even collect and bring for us in the facility. So teamwork is the key for the success of the program, actually. The national level alone, they cannot do it. At the state level alone, they cannot do it. This has to come down to the facility level and the community level. And we are the ones privileged to be at this facility level. So I'm using this opportunity to encourage each and every one of us to come on board. The chairman said in his opening speech, in his opening statement, he said he could remember 15 years ago when they used to compound anti-TB drugs for children. These days, I do not know about some other places, but in the FCT, quite a number of pharmacists are truly not involved in TB. In fact, a lot of colleagues do not even want to have anything to do with TB patients because of the risk of infection. But thank God for COVID-19, quite a number of us now, we are now using our face masks so we can easily prevent ourselves. Okay, so these are for the NTB strategy, the goals and the high-level targets. It is expected that the goal of the strategy is actually to end TB epidemic in Nigeria, and the indicators for 2020, 2025 to 2035 are there. We want to have a reduction in number of TB deaths. By 2020, we wanted to have reduced by 35% compared to 2015. But unfortunately, because of the global pandemic, the COVID-19 issue, there was actually an increase in the number of deaths recorded from 2020 to 2021. But hopefully, by the time we get to 2025, let's say we should be able to get up to 75% reduction. And at the end of 2035, we would have reduced the number of deaths to about 90-95%. So TB reduction in TB incidence rates by 20%, 2020, by 50%, 2025, when compared with 2015, and like that. Now, I actually quickly want to just say this, that we actually want this percentage of TB patients and their household experiencing catastrophic costs due to TB to be zero completely. And I believe with all the donor agents that we have, with the National TB and Leprosy Control Program, and all the volunteers that we have on ground, with you and I joining our hands together, we will be able to achieve this. Now, quickly, I want to show us objective of infection control, because this is key in us achieving the NTB strategy goals. Now, if you look at this, you will notice how people are jam-packed. This is a typical GOPD settings, and I want to say this should be discouraged highly. But at the same time, when we have this, we can actually use the opportunity to educate people on the proper settings. COVID-19 has actually helped us a lot. Like in my facility now, people do not sit like this again, but maybe we still have them like that in some other facilities. We can actually now use our infection control strategies to isolate anybody that is coughing And we now try as much as possible to educate them. If possible, provide them with face masks or teach them how to cough into their handkerchief. So quickly, this will be my last slide. Quickly, this is just a brief summary of what I've said about infection control and prevention so that we can prevent the transmission of tuberculosis in all settings. Now, these are the actions that I want you to take. Step 1 is to screen. Early recognition of patients with suspected or confirmed TB cases is actually the first thing. After screening, try as much as possible to educate them by instructing those people that you have identified through screening on cough hygiene. Then this includes instructing them to cover their nose, as I've said earlier. Then you can now separate them from other people. Patients who are identified as TB suspects or presumptive cases, or even the actual cases, can then be screened by questioning them. They must be separated from other patients actually, and requested to wait in a separate, well-ventilated waiting area and provided with a surgical mask, tissue, and any other one that you can provide them so that they can cover their mouths when talking, when sneezing, and while they are waiting for further action. Then you can now provide services for this set of people by doing triaging. Those people that are in need of urgent services, you do not need to keep them with other people. Those people that are TB positive, immediately you offer the services that they require. And those people that need to be investigated, you refer them if you cannot do the investigation in your facility. These are the few references that I used, and with this, I want to employ all of us to give more, do more so that we can end TB in Nigeria. Thank you very much. I'm sorry for the technical issues. Thank you.
Thank you very much, Pharmacist Benga, for doing justice to the topic. The first presenter was the national, what it entails to end TB at the national level, while the second presenter took us through what it entails to end TB at the facility level. Thank you very much to the both speakers for doing wonderfully well and doing justice to the topic. So without wasting much time, we are going straight to questions, comments, and contributions. And we have from Adeboke, his hand has been up since. You can unmute yourself and speak. From Adeboke, you can end screen sharing.
Good afternoon. Hello. Hello.
Hello, we can hear you. Go ahead. Hello, we can hear you. Go ahead.
Good afternoon, distinguished colleagues. My name is Adeboke, and I don't know, because I actually written my question in the present first comment the presentation. They really that with this topic, even though they had just a very short time to prepare. But I may be wrong. Maybe this have changed now, because I must confess I'm not the one that have been following the TB program in the last 4 years. Pharmacists are just very few. Pharmacists that are contributing to TB control program, they are very few. Maybe for one pharmacist, likely about almost 10 social workers, and then medical doctors. I'm here to call us nurses who actually are, carry the patient. I don't know why disease.
Okay.
And the email, yes. Yeah, are you hearing me? Are you hearing me?
Hello, sir.
Hello.
Your network is very bad. Your network is bad. Your network is very bad, sir.
Okay. So sorry. Are you hearing me now?
Moderator. Farmer
You are not audible. You are not audible.
Farmer Sat.
Yes, sir.
He has already dropped. Kindly check his question on the
now.
He has already dropped it on the chat box. You can read it from there.
I already did the question on the chat. Just a minute. All right. I think that's the first time. Okay.
I think you can mute yourself now. So he wrote a great thank you to the presenters and the organizers of the program. My observation is that it says that only few pharmacists are engaged in TB control program. Why is it so? What can we do to encourage more pharmacists to contribute in this area? From Lawrence, you can respond to this.
Okay.
Pharmacist.
Yes, I'm here. Can you hear me?
Oh, please respond to that. He said, why is it that pharmacists are not involved?
Okay. So, I don't know. Can you hear me?
We can hear you, sir. Yeah, we can hear you.
Okay. So, that's a bit worrisome. That's a bit worrisome. And I think it begins with interest. I know some of us here are old seniors, and I want to draw your attention to what happened to NHIS. When NHIS came on board, a lot of pharmacists ran away from NHIS. Until today, we are still suffering that. And the same thing to happened when TB started. Not many pharmacists were involved, even though now we're a bit much many now, but still the gap is still there. All right, so what is the way forward? The way forward is number one, interest. If you are interested, you don't want to go into TB, it's very simple. The second presenter talked about the issue of volunteering. You need to get on board. We welcome anybody who's interested, who wants to. In fact, we're looking for people to come on board and join us in the team, right? And when it comes to commodity management in the TB space, it's strictly reserved for pharmacists. Vis-a-vis commodity management, health technology, and all of that is under our purview. Okay, so we are even looking for people to come on board. So it's interest, and if you are willing, why not? But start with the place of volunteer. Wherever you are, go there, volunteer with them, and then you can scale it up to the national TB. That we have these people who are interested. What can we do with them? There's a lot of room for pharmacists to come in. Just last week we were in Port Harcourt, and a pharmacist came, a PhD student, a pharmacist came on board and showed interest. And when he came, we welcomed him and we told him what to do. We gave him hands of fellowship and said, look, fix yourself with the Port Harcourt people, River State team, and do what you can do. So that room is open. It's interest. If you are interested, there's room for anyone and everybody. Thank you.
Thank you very much. Pharmacist Maureen.
Good afternoon, all. Please, I hope I can be audible.
Yes, we can hear you, please.
Please, I beg to differ with the last person who responded to someone's question. You said, and during NHIS, we shied off. During the tuberculosis, we shied off. And even during the NHIS, we are paying for it. I want to let you know that we never did any sort of those things. We pharmacists don't. In fact, we are not included. Do you know, it is now I'm actually trying to fight for us in my own practice to find out what is happening under the NHIS, because the physicians take hold of it. and try to head everything and try to hide whatever they think they want to gain from it, or if there's anything to gain from it. So please, I don't want you to say that. Now, if we didn't fight for the COVID-19 stuff, we won't be there getting any what the response we are having now. Please don't use that statement. We shied away from it or we ran away from it. Please, I bet I'm just really highly not happy with that statement at all. Now, to talk about volunteering for it, let me tell you in my practice, it was the nurses they called for this tuberculosis training. They never regarded us, the pharmacists. When they've now brought the drugs, they wanted to now give it to the pharmacy to keep. We said, no, we're not going to take the drugs. We don't know, even if they are for TB patients, we don't know where it came from. We don't know the storage, how they stored it and everything. We refused to collect the TB drugs. You cannot send some specific people for training and avoid the people that is even going to store the drugs. After so much pleading from the management, that was when we now took the drugs in and kept it in our custody. And as I can assure you, none of us was still sent for the training. So please, I beg you, please don't use that language that we ran away from it or we shied off from it. I have to come in, please, I beg, I don't, please.
Thank you very much, Pharmacist Mori. I think initially, the problem of policy, the problem started from the policy part. And that's why we're encouraging more pharmacists to join politics. Because if we are not there, all these policies will be made and will be left behind. So we thank God, I think there is improvement, because during the COVID-19, I think pharmacists were there, we fought and we are there. So I think the initial problem was the policy, it was at the policy level. So thank you, Pharmacist Gabriel.
Thank you so much, ma'am. I just want to align with the last speaker. National Chairman, sir.
Yes, I can hear you.
I don't know the. Okay, thank you so much, sir. I recall very vividly about 16 years ago when I was in FMC Jalingo. We had this workshop concerning TB, and I raised this concern because I recall very vividly that pharmacists were not involved in the commodities. And when I made this observation, I was shut down. Then I was just a young pharmacist. They felt that I shouldn't make such an observation. I've worked in several federal hospitals or done business with several federal hospitals, about 15 of them. And I can tell you, sir, that the people in charge of TB are not pharmacists. So we need to discuss around this issue, because when it comes to and the issues of TB, like I'm with the gastro team, and we are seeing cases where people are coming who are on anticoag and they have issues with their liver. But because pharmacists are not involved, they don't even understand how to pick these things from the. So I think as a
Pharmacist Gabriel, they are not audible again.
Yeah, I think his network is bad. So maybe you take others.
Okay.
hello, sir.
Yes, we are hearing you now.
Okay. Did you get, National Chairman, sir, did you get my last submission?
So the last submission was not, you were not audible. You didn't get the last part.
Okay, what I said is that I've either worked or been involved in 15 federal hospitals in Nigeria. And I realized that pharmacists are not involved in the management of TB. And I raised this concern about 16 years ago when I was in Federal Medical Center, Jalingo. And no good reason was given. I'm currently with the gastro team in my hospital. I'm the pharmacist in the gastroenterology team. And we are seeing patients with deranged liver function tests who are on anticox. And these are all the pharmaceutical care that we could have brought in as pharmacists. So as an association, we need to look into the
You are not audible.
The network is bad though. Maybe you send a message to me later from Gabriel.
Yeah.
So that we'll look
Thank
at
you, Pharmacist Gabriel. I think what you are trying to say is that the association should look into it and see how pharmacists can be involved. Pharmacists, you're raising your hand. Maybe you tell us how.
Exactly, that's what I'm trying to say.
Your facility.
Yeah, exactly.
Because the truth of the matter is, right from among all the FCTA hospitals that I know, it's only Kuje General Hospital, that's where Pharmacist Benga is, that pharmacists are involved in the TB program. So, Pharmacist Benga, you can chip in one of two things and tell us what happened that you find yourself fully involved while other facilities are lagging behind.
All right. Thank you very much, Chief. To be sincere with ourselves, a lot of pharmacists are not interested in the program. That is what I've seen. For me, I think my own started with interest, actually. Then I was privileged to work with someone who is keen and highly interested about tuberculosis. That is my HOD, pharmacist Sam Taylor. When I came into the system in the year 2014-15, like that, I used to see him attend to these TB patients, and each time he's attending to them, he will call me. I wasn't the only pharmacist working with him. He will call us, actually. But, you know, interest is the key. I always follow him, watch him how he does his things and ask him questions. And from there, I became highly interested to the extent that I started attending to patients. And eventually, around 2018, so imagine something you started doing from 2016. In fact, 2015, without any form of training, without any form of recognition. See, 2018, when my chief now said, okay, we can make you the dot focal person, since you are very serious about this TB and you are highly interested. And that was how I became the dot focal person here in Kuje General Hospital as a volunteer, actually. And to be sincere with you, for my colleague that was talking about training, I wasn't trained initially. It was just the interest. So each time the team from the FCT team visit us here in Kuje, they will meet me. I'll be the one to attend to them. So, you know, with time, they started asking questions. Have you been trained? Have you been? I said, no, I've not been trained. And they kept on promising. Eventually, the training came, but it's not as if they will just come and call you, say, okay, so person, come for training. No, they will invite people that are interested in the program. And from my experience, with all the trainings that I have gone for, sincerely speaking, I was the only pharmacist, at least at FCT level, that the ones I've seen, I was the only pharmacist that way. When I came back, I told my HOD, he said during their time, there were more pharmacists, but unfortunately, the number kept reducing. What you see these days, you see community, and what do you call them, these CHU, they are the ones running these programs now at primary healthcare level. So for me, it has to do with interest. We should try as much as possible to, volunteer, and with time, training will come.
Thank you very much, pharmacist. I think it has to do with interest and policy. Pharmacist Hassan Abdul Salam, are you there? Pharmacist Hassan Abdul Salam, your hand is up. We'll take 3 more people.
Can I go on talking?
Yes, sir.
Okay, good afternoon, colleagues.
Good afternoon.
It's been very nice talking to you, being among you today. And it's a very good presentation by Pharmacist Lawrence and the other presenter. You have done a very good job. In respect to our being involved in the management of care for TB patients, I think I had this issue that I'm really concerned about. The issue of 1.9 million children coming down with tuberculosis. This was a case I raised when I was working with Barodico Specialist Hospital in Kaduna, now Barodico Teaching Hospital, with the TB and leprosy control unit. Then I was the one in charge of their drugs, and I raised the concern that, well, how come children are coming up with TB after they must have gone through the normal vaccination or immunization that they normally come up with? It's a thing that we really raise, because quite all right, most pharmacists were not really involved in the treatment schedule of TB patients then. And as I then, for those that have been working with this unit, they know that most of the drugs that we have in the management of TB and leprosy then were all for adults. They are all in tablet form. It never comes in for pediatrics. There was no any concern for pediatrics then. So I raised this question: how did the children, how are they really coming down with this TB after they must have been immunized at birth? Well, some people said probably the parents did not take the children for immunization when they were born. Some said, well, maybe the vaccines that the children were immunized with, there is this issue of vaccines break, because probably during the process of the cold chain was not really maintained in most facilities. So this is something that we pharmacists have to get ourselves really much involved in. As at that time, I think I had the opportunity to start preparing extemporaneously the drugs for children, because I had to be using vitamin B complex to prepare most of the syrup for children at that time. Because of course, if you are taking TB drugs, you all know some of the basic side effects, this peripheral neuropathy and so many other things. So I now started using vitamin B complex to prepare the syrup for most of the children at that time. So this concern, how are the children really coming down with TB? This is the most important thing that I really wanted to raise, and it's still very concerned now. And with the presentation that Pharmacist Lawrence has presented, he's still talking about 1.9 children are really coming down with TB. How? With all issue of vaccination, immunization, and so many other things that are around. If the immunization has been going very well, I think TB should have been something of the past now in our country. Because from what I'm saying now is around from 1998, I left Barodico Specialist Hospital around 2004. So from 1998, when I was in Barodico, to 2004. So this time around, you should have known that, of course, this TB should have been something that has been of the past. But here we are today, we are still talking more about TB. And moreover, TB is more in the among those that are not economically advantaged. So that maybe that is the reason why there is no much effort. If we had put efforts like we have done with some of these current infections that are coming up, maybe the campaign will have been more stronger and they will have wiped out the disease. So I think this is my very much concern about the children coming up with TB, tuberculosis. Thank you.
Thank you very much. I think I will give Pharmacist Lawrence just 30 seconds to respond to that. Then we'll take 2 more people and we'll wrap up.
Okay,
Pharmacist Lawrence.
thank you. Yes, can you hear me?
Yes.
Okay, thank you, Pharmacist Hassan, for your observation. And this is true and also worrisome. First of all, I want us to understand that science is not static. Medicine, as it were, changes over time. And we do know that we give kids vaccines. And what you are raising is not particular to Nigeria as a whole. So if it was particular to Nigeria, I would have said, okay, maybe it's our system, maybe it's the coaching, maybe it's the practice. But this is a global figure. So what readily comes to our mind is the change in medicine, the fact that it's not static, as it were. These things keep changing over time. So there's no straitjacket answer to your question, how kids are actually coming down with TB. But again, if you do a cohort analysis, if you have read literatures well, you will discover that most times children who come down with this TB are children, of course, who, like you said, live in these rural areas, number one, and number two, whose parents have in one way or the other contacted these infections before. They are usually contact of index case, or as the case may be. So that's what we see as a trend, which again, we may need to do an operational research, perhaps, to wanting to do a deep dive. Why is it so? In the National TB program, we even know that they are there, but getting them is also a challenge for us, because again, to get sputum from children is difficult. So you may need to have to devise other means to be able to get and trace them and get them. So with kids particularly, there are a lot of things that revolve around them, which again is not very clear. You understand? So these are areas we're actually looking at to do a deep dive further and do further operational research to know why it's actually so. So there's no one straight jacket to providing your response to this issue of children who come down with TB. But let it be registered that if you do a cohort analysis, most of them are actually gotten from parents or people or supporters who have one time or the other contacted this infection. And like we said, TB is inherent already, it's there. However, when your immunity goes down, it pops up. And with kids who are growing up, their system is dynamic, changes here and there and there and there perhaps. However, it's subject to still further research and analysis. Thank you, sir.
Okay, thank you very much. So we'll take Dr. Momo, Pharmacist Lotto, then we'll wrap up. Dr. Momo.
Okay. Can you hear me?
Yes.
Hello.
Go ahead.
Okay. Mine is basically comment. I'm with the first 2 speakers. talking about pharmacists, a few pharmacists taking interest in TB. And if you notice, we have more pharmacists in HIV and malaria compared to TB. And basically, this still boils down to interest. And I have that experience even when I was at the state level. Then there was a letter that came in looking for a pharmacist to take over the logistics of TB. And almost all the pharmacists from the hospital management board rejected the offer. So I was then selected to take over. Even me then, I had no interest in TB because I was already doing HIV. But I took up that bold step to add TB to my HIV practice then. HIV. Can you hear me?
I'm hearing you. Go ahead.
Okay. So that's how I took interest in TB. And what I noticed then, when I took that, there was no training. I took TB up, had to learn on the job. Then it was even later that training came up. And most of the training I went for, similar experience. I was the only pharmacist there. And we had other CHUs managing TB. And then I had to take over TB management at state level. Even when I was leaving TB at the state level to national level, handing over to a pharmacist even became a challenge, because even pharmacists then, my colleagues were not even interested in taking over TB commodity management. And it's still like that. So my advice is, if pharmacists needs to take charge in TB, nobody will hand over TB management, drug management, or even part of TB this thing to you. We as pharmacists needs to take over TB commodity management in our respective practices, whether hospital, federal or state hospitals. We pharmacists need to take over TB commodity management, and that's where pharmacists will enter the program. Without that, if we sit down, cross our leg, and we are expecting the TB program at state or national level to come and meet you and hand over TB commodity management to you, it won't happen. So that's also part of the comment I want to make. Then secondly, regarding the increased TB cases in children, we know we have the BCG vaccination. Now, the BCG generally protects children more in the extrapulmonary TB. It has more protection for children for extrapulmonary TB. So for cases of TB in children is usually from adults that are positive for TB. And diagnosis for children is usually more difficult because you can't get sputum, you can't get children who produce sputum, and their symptoms are not as clear as that for adults. So, but for the national program, we are having other diagnostic methods that have been developed, which they are using now I think they are using stool and other body fluids for children so that they can increase TB detection in children more accurately than previously, as we all know. So, thank you, Anova. That's my comment.
Thank you very much, Dr. Momo. I think the national chairman, I don't know that you chip in one or two things, especially regarding the issue of interest and policy.
Yes, thank you very much, Moderator Afsat. I really want to appreciate our guest speakers. The two of them have done very, very well. I also want to appreciate those that have passed or made one comment or the other. The issue of interest, I can't make any categorical statement because I've not really done any kind of survey. But from what we have had on this particular platform is like in some places, some people who were called actually rejected it, whereas there are some places where pharmacists are actually interested. I want to actually put on record that when I was a younger pharmacist, I remember then, because I'm in charge of drug production and quality assurance in my facility, just like pharmacist Gabriel said, that they were doing compounding of rifampicin and all that. We also do that at FMCO. We were doing it regularly. But I remember along the line, there was a kind of policy somersault, and I remember then that the issue of what is it called, giving anti-TB was now moved to the primary healthcare centers. And before then, we were actually stocking anti-TB in our hospital, but along the line, it has to stop because no such patients was coming to my facility anymore. So they were now going to the primary healthcare center, a designated place in town, where they were all taking their drugs under the DOT program. So that has actually been in place. So it does not now translate to the fact that we in my own facility don't have interest. So that's why I said I cannot say for all the various facilities. And someone just mentioned that they were asked to take over the TB store or stock or something like that, and nobody responded. So it means that while some people were interested in some places, in some other places, some people may not be interested. So we cannot make a blanket statement in this case. But all I just want to say is that when we have the opportunity and they ask us to take charge of anything that has to do with pharmaceutical, I think we should just grab it. That is what we are fighting for. It's like asking the store officers and all that to take charge of our store, and we say we are not interested. We should be interested anywhere pharmaceuticals are. That is the main substance in pharmacy practice. So I just want to say once again that for those that have the opportunity, let us grab it. And like it was said by pharmacist Lawrence, he said we should show interest. He has given us how we can go about it for people that are still interested. But for institutions like mine, for instance, now they don't treat TB here. So any TB patient is referred to that primary healthcare center, like I said. So although they see TB patients, people that have comorbidity with what is it called, HIV and things like that at their clinic. So, and they give whatever they need at that level. But there is no specialized clinic for TB patients. So that's what I can say about that. And before you wrap up, please, I just want to use this opportunity to recognize someone in the house. The person happens to be a national officer of AHAB before. That is pharmacist Mrs. P.T. Oluwatayo Omotoyinbo. I want to actually recognize her especially because I owe her a lot of gratitude. She was my head of department, Pharmaceutical Services Department, Federal Medical Center, before she retired. And she had always shown interest in anything that AHAB does. In fact, I was surprised to see her again on board. When I just checked through the list of participants, I saw her again. I said, this woman that has nurtured us, she still wants to see that we are making progress. So I really want to express thanks and appreciation to her for coming on board, for being a part of this particular program. I just felt I should mention that. Thank you so much, ma'am.
Thank you, Chairman. You're welcome.
Yes, ma'am.
We continue to pray for your progress.
Amen.
And that of pharmacy profession.
Amen.
So it's
Thank
good
you
to
very
log
much,
in
sir.
so that one could keep on abreast of the latest in the pharmaceutical world.
Yes, ma'am.
So thank you all. God bless you all.
Thank you so
Thank you,
much.
ma'am. Amen.
So, Pharmacist Absat, over.
Okay, thank you very much, sir. Closing remarks. Pharmacist Gabriel Akilekunu, the chairman of Education Committee, AHAP National, give a brief closing remark. Our host, Pharmacist Norman,
Okay, thank you.
now give a vote of thanks.
Okay, thank you, Pharmacist Hafsat Abdullahi. I want to use this opportunity to thank guest speakers, Dr. Lawrence and Pharmacist Benga, for making our time to share their knowledge and experience with us as we celebrate the World Tuberculosis Day. I also like to appreciate the National Chairman for giving us the opportunity to coordinate this program. I want to say that from our committee, we want to do this very often. The next World Disease Day, we are going to reach out to all of us, and we are going to bring speakers that will speak to us concerning those disease dates. So on behalf of the committee and everyone who has put this together, I say thank you and God bless. Thank you so much.
Thank you very much.
Host,
good afternoon.
Please vote of thanks.
Thank you. Good afternoon. I'm online.
Welcome.
Thank you very much. Good afternoon, my national chairman.
Welcome.
Thank you, everybody. God bless you.
The speakers of today, and all amiable pharmacists present for today's program. I want to use this opportunity to thank our amiable national chairman, FAM FPSN Olabode Ogun Jemio, for deeming it necessary to commemorate this year's 2022 World TB Day. On behalf of AHAP National and AHAP Abuja, I want to say another big thank you to our resource persons, FAM Dr. Ekocha Lawrence and FAM Benga Adewumi, for doing justice to the topic of this year's TB Day commemoration. Thank you, our moderators, FAM Hafsat Abdullahi and FAM Gabriel, for moderating the Zoom meeting in an orderly manner. We really appreciate all your efforts. Then finally, I thank everyone for taking time to be here today, for listening and contributing to the success of today's program. Without you, it won't have been possible. Thank you, everyone, once again. Have a nice day, and God bless you all.
Thank you.
Very much,
From Hafsat.
Yes.
Yes.
So this is Lawrence online again. Just to say that anyone who would like to reach us is free to reach out to us for discussion on what we've discussed today. We are open and can always reach out and discuss. Thank you very much.
And we have your slides. Are they still available?
Yes, I can share with Madam Hafsat, then she can now.
Please, she can pass it on to others.
Yes, I can do that.
Thank you. Thank you.
We'll share the contact. We'll share your contact too, if you permit, for people that want to reach out.
Please, Ma, go ahead.
Thank you very much. Closing prayer. Dr. Momo, I don't know whether you're still there. Can you give us prayer?
Hello?
Yes, sir.
Dr. Momo, are you there? Pharmacist Hafsat, you can close the meeting with the word of prayer, please.
Okay. We thank God for the success of this program. We pray for more success as we celebrate more World Health Day. Alhamdulillah, Rabbil Alameen. Thank you very much, everybody, for your time.
Thank you very much.
Thank you very much.
Bye.
If your inquiries were not answered, please we'll reach out to you. Those that send will get across to you the answers to your inquiries, please. Thank you.